assessment, same as on every one of your assessments. First thing I'm going to do is come into the room, introduce myself, provide privacy, wash my hands, introduce myself to the patient, and explain the procedure. So I'd come in, wash my hands, tell the patient I'm coming in here to do an assessment. And then what I do is while I'm talking to the patient is now I have the opportunity to actually do somewhat of a general inspection. And you're going to put gloves on. I'm not going to put them on because I have my ring on, but you have to have gloves on to do your assessment, just so you know, because you're going to be touching stuff, so gloves, infection control. So I have my gloves on. While I'm standing here talking to the patient, one of the first things I do is generally observe what the patient's doing. So do they have appropriate demeanor? Do they have a bad smell? Are they acting odd? Is their affect appropriate? You know, if you walk in and somebody's crying and they're laughing at the same time, that kind of makes you wonder what's going on. So general inspection is just looking at hygiene on the patient. Do they look, you know, they have stubbles and they need to shave? Do they look dirty? So just your general inspection. Any rashes on the skin, anything like that. Next thing I'm going to do is ask the patient if they're having any pain. And if they are, I need to assess their pain. So pain is considered the 5th vital sign. So we need to, if they're having pain, we need to give them a scale. So you can use the FLAC scale if your patient's nonverbal, Long-Baker scale. You can use Long-Baker, you can use FLAC, or you can ask the patient on a scale of 0 to 10 if 10 is the worst and 0 is none. It's not 1 to 10, it's 0 to 10. Because if you give them 1 to 10, they can never be without pain, right? So 0 to 10. 0 is least, 10 is the most. Okay? Then you're going to document that. And you're required to document pain. If the patient does have pain and you administer pain meds, you have to come back and you have to reassess to follow up to make sure those pain meds are working effectively for your patient, or that would mean you would have to implement some other type of intervention, correct? So if they do have pain, when you're doing your assessment checkoff, we will tell you, yes, I have some dull pain to my head, and you would need to do something. So you would ask, what's worked for your pain? What have you been taking? If they've been taking Tylenol or something like that. So you guys, these would be questions and stuff we'll be giving you as you do the assessment. Next thing is we're going to do A&O. So alert and orient patient. How do we do that? 3 ways. There's 3 questions you need to ask. What's your name? Who are you? So that we know that they're oriented to self. Where are you? And I usually ask them what year it is. Please do not ask your patients political questions like, who's the president? Because that makes people mad sometimes. So I tend to not use that question. You hear people say it and they're like, well, I know it. Just ask them who they are, where they are, and what year it is. Okay? So if they answered 2 of those correctly, they would be A&O times 2. If they answered 3, it'd be A&O times 3, so that we know that they would be alert and oriented and intact. Yes? Okay. So we're going to ask them that. Vital signs, it says take vital signs on here. You guys have already checked off on vital signs, but when you check off, we will give you a set of vital signs. And at that time, we will tell you the vital signs and then ask you, do you have any concerns about your patient's vital signs, or are these all within normal parameters? And if there are any that are abnormal, what would you do? So be prepared to answer those questions when we ask those. Next is going to be, I'm going to do his eyes. Perla. We're going to be checking for Perla, and I'm going to ask you, if I check you off, you might as well already plan on it, and the others will. What does Perla stand for? So, because patients are going to ask that. If you go in here and say, I'm going to check Perla, they're going to say, what's Perla? What's Perla? So, pupils equal, round, reactive, delight, and accommodation, and you need to know each part of that. So, when I'm going in here, I'm going to look at my patient, which this one doesn't have any eyes, really, pretend, and you're going to come in here with the light on and over here, and what are we going to be looking for? Pupils equal, round, and reactive. So I'm looking right now at his pupils, so I'm going to, look and say, are they round? Yes. Are they equal? Because sometimes you'll have some that have, maybe a 3 on one side and a 5 on the other. So are they equal, round, and then reactive? When I take the flash in, what happens when lights go into eyes? What does the pupil do? It constricts. So I'm looking to see if it's actually constricting. And I'm going to come over here and do the same thing and see if it constricts as well. Okay? So pupils equal, round, reactive, delight. Now accommodation, take the pen like this, and I'm going to come in, and I'm going to come out. And what's going to happen when my pen goes in to the pupils? What are the pupils going to do?
Cross their eyes.
Well, they're going to cross their eyes, but what are they going to do? They're going to constrict when I go in, because they're going to focus and constrict, and when I come out, then they'll go back out. So when they focus and come in, they should constrict, and they should actually both come in. So if I had one eye that came in and one eye that went out strabismus, then obviously that would be a normality that should be documented. Yes? Okay, so that's how we're going to check for PERLA. Make sure that you understand what PERLA means and each part of that, what it means, because you'll be asked that. Next thing, we're starting at the top, so I'm going to inspect the ears here. I'm going to be looking at the ears to see if they're equal. Look where they're set. Are they low set? Are they normally set? The top of the ear should actually be almost level with the corner of the eye, the canthus here, outer canthus. So they should kind of be that way. Sometimes you have people that have lower set ears, so that's what you're going to be looking at. You're going to be looking if there's any drainage coming out of the ears, any cerumen coming out of the ears. Maybe they have hearing aids in place. So those are going to be some things you're going to be looking when you're looking at both the ears. Next, I'm going to be looking at the nose. I like to look up inside their nose, and I usually pull their nose back, especially if they're in with respiratory stuff or whatever, because I want to look at the turbinates. Are they boggy? Are they swollen? Are they red? Are they inflamed? Are they just full of junk? So I want to look up in their nose. I'm looking at the septum to see if it's deviated or if they have a straight septum. Okay? What if they have one side that's completely occluded? I had a patient before I had to put an NG tube in that came from the state school, and we literally had to put saline up to clean his nose out because it was packed with boogers. We couldn't even put an NG tube in there because there was so much boogers packed in there. It was probably one of the most disgusting things I ever had to do. So look in their nose, is it patent? Because if their nose isn't patent, they're going to have a lot of breathing issues. The next thing you're going to do is you're going to palpate the sinuses, so it's important that you know where the maxillary sinuses are. Not so much the ethmoid or the sphenoid sinuses, but we're just going to palpate in here, see if there's any pain. We're going to palpate up here if there's any pain. Patient doesn't say there's any pain, then there's not any pain. I'm going to look into his mouth. I'm going to take, and you're going to be using a pen light when you look in their nose and their mouth. I'm going to look in his mouth. I guess I can hold this so you can see. I'm going to look in here in the dentation. I'm going to see, do they have all their teeth? Do they only have one tooth? Are they missing a bunch of teeth? Do they have a lot of cavities? Does their breath smell bad? Do they have a partial in there? I'm going to be looking for any ulcerations, any type of white coating. They might have thrush. If there's any sores. And you want to make them lift their tongue up so you can look under the tongue. And you're going to look on the roof of the mouth and the palate. If they have strep, a lot of times you'll see petechial areas on the palate, the upper palate. So I'm going to be looking all in here and around that way to make sure everything's intact. Okay? If they have bad dentation, that can be problems because it can lead to other issues. So we want to make sure we check their mouth. What else would we be looking for when we look in the patient's mouth? What's something important?
Airway obstruction.
Airway obstruction, we look for that. And we also want to see, is it moist and is it pink? Because if it's dry and they're all cotton mouth, that could be indicative of them being dehydrated, or it could be side effects of medications they're on. And if they're dehydrated and their mouth is not moist, that puts them at higher risk for developing ulcers and other issues. So we're going to look in there. You're going to have the patient smile for you, and we're going to look at their smile to see if there is symmetry, and why is that? Stroke. So we're going to look for that. So you have your patient smile. And we're going to come down here and we're going to palpate the lymph nodes up under here, submandibular, anterior cervical, submental. We're going to feel all these down here. You can go to the back and feel posterior cervical, post-auricle, pre-auricle. You can feel all these lymph nodes, and you're going to be palpating. Is it normal to feel lymph nodes? No, it's not normal to feel lymph nodes. If you're feeling lymph nodes, there's probably some type of inflammation in that area. Okay? I mean, if you jam in there, you might be able to feel them way back there, but if they're swollen and you can feel them, that's not normal. All right. Also have the patient swallow, check the swallowing ability. So while you're palpating here, and I'll usually let them have a glass of water or something and just tell them take a drink, and I'm just going to be feeling and making sure that they're swallowing okay, and if they start to cough or have any issues, because that would be concerns for aspiration. And sometimes stroke patients may be able to smile and have a symmetrical smile, but then they aspirate the fluid, so that would be a concern at that point too. Any questions so far? You guys all looked at this sheet, right? Okay. So next thing we're going to do is you're going to inspect the patient's chest. And when we say inspect the chest, you just want to have a general look at the chest. So I want to look at his chest. Maybe this was a cabbage patient. Maybe he has a sternal incision. I want to make sure everything looks okay. So I'm going to be looking at the chest, seeing if it's rising and falling symmetrically. Because if one side's up and one side's down, we have a problem, yes? So your chest should be symmetrical on both sides. I'm going to be looking for any type of rashes, abrasions, incisions, anything like that. When I finish this whole assessment, and you guys should be doing the same thing, there should not be 1 inch of this patient's body that you haven't seen with your eyes. You need to see everything. Yes.
If that's a woman, would you do that? Like the chest?
I would look down in the chest, yeah, because when I listen to heart sounds and lung sounds, I mean, you don't have to pull it down like that, but I'm going to pull it back, and I'm going to look down in here, even if it's a woman.
Okay.
And if it's a woman, I'm actually going to lift the breast and look under the breast as well to make sure there's no yeast or anything like that as well. But you should see on your assessment every inch of their skin, because if there's any breakdown or any issues and you miss that, it can be a big deal. So I'm going to look here. I'm watching for rising and falling, looking for any rashes, incisions, anything like that. If you have any labored pain or any labored breathing, anything like that. Next, I'm going to listen to the breath sounds. And noted on here, it says define rales, crackles, bronchi, bubbling, wheezing, stridor, and choking. So you should know how to define all of those, because you will be asked to define those. So make sure you look in your skills book. It defines every one for you. And there are some different websites you can go to listen to breath sounds so that you know the difference in them. But you need to know, because if you don't know, then you don't know. If you don't know the abnormal, you're not going to know it's normal. So you need to know. So listen to what a wheezes sound like. Listen to what bronchi sounds like. If somebody has bronchi, we can have them cough, go back and listen again, and sometimes they've cleared it out. So there's different things with each one. So make sure you know those. Make sure that you know your spots for your anterior and your posterior lung sounds. So you guys should know, when I'm listening to my breath sounds on the front, my anterior spots, there's 10 spots on the front and 18 on the back, and you cover all 10 and all 18. Real life, we don't do that, but for testing purposes, you're going to do it. So I'm going to actually listen here. So I have 1, 2, 3, 4, 5, 6, 7, 8, 9, and 10. And you notice that when I'm going back and forth before I drop down, because you're comparing breath sounds. So when I'm saying 1 and 2, having them take a deep breath, I'm comparing the right side with the left side. Then I drop down here and say 3 and 4, I'm comparing the left side to the right side, and 5 and 6, like that. So we don't go all the way down this way and then all the way down that way. It alternates side to side and over, because you're comparing each part of that lung to the other side. Y'all picking up what I'm putting down? Okay. If you do have abnormal lung sounds at any point when you're listening to the patient, and they'll ask you this, if you hear stuff rattling around or whatever, what are you going to have the patient do? You're going to have them cough, and you'll reassess. Because sometimes they can clear that. When you first go in to see somebody in the morning, they may have woke up and they have a bunch of stuff that's settled in there and just junky. If they set up and have a good cough, a lot of times they'll clear that. So if you're asked if your patient has abnormal breath sounds, what are you going to do? You're going to have them cough and reassess. Then you would document what you hear at that point. Okay? All right, so on the back, we're going to have 18. This might be a little bit harder for you guys to see because he's not going to move, but... And this is all listed in your skills book. So you're going to have 18 spots. So we're going to have 1 and 2, 3 and 4, 5 and 6, 7 and 8, 9 and 10, 11 and 12, 13 and 14, 15, 16, and 17 and 18. So you're going to have 18 spots on the back, and you want to cover them. And you should alternate left to right, right to left to right, right to left, because you're comparing sounds. Okay? So now I'm already back here. I've got him setting up. Next I'm going to do is I'm going to look at the back. I'm going to look down in the sacral area of the coccyx to make sure there's no breakdown. See if his spine is midline, and if it's even, if there's any lordosis, kyphosis, anything like that. That's all stuff I would document. So I'm looking at the back of the head, making sure there's no breakdown. These are all breakdown areas on the scapula. All this, looking for all kinds of breakdowns. Okay, so I've seen the whole front and the whole back at this point. And I'm looking at part of his buttocks here. But I would actually I'm going to have him roll over in a minute so I can see both sides really clear. Any questions so far? All right, so next thing I'm going to do, I'm going to come over here. Make sure you guys look at another definition block: ecmosis, erythemia, jaundice, petechia, and decubitus. You guys need to know those definitions as well. Okay. And then it says verbalized signs of physical abuse. So what that means, if you come in here and you saw a lot of bruises, maybe some new bruises that might be black and blue, maybe some that are yellow, some that are green, some old bruises. If you saw that, what would you do first?
Ask how they got it.
Ask them how they got it. What happened here? What happened there to here? So if you suspect that, and you can suspect that in any age group, it's not, and it's not just for one age group. In the elderly, in the young, in the pediatric patients, if you see anything that seems like physical abuse, then you need to assess it and ask the patient. So we'll ask you about that. All right, so next is going to be heart sounds. This is going to be important because you need to know all your landmarks, and I will ask you your landmarks. So first is going to be aortic. All right, so aortic is going to be right here, right, second intercostal space, right sternal, second intercostal space. Everybody knows the sternum is this big bone right here, and then second intercostal space should be right about here. So I'm going to be right of the sternum, second intercostal space, and I'm going to listen. And you guys that have these type of stethoscopes, you should listen with your diaphragm and then with your bell. So you should listen on both sides. Next is going to be over here to the left sternal border, second intercostal space, is going to be the pulmonic. And you better be to tell me which one, aortic, pulmonic, mitral. So be familiar. So right here is our pulmonic. Left sternal, second intercostal space is going to be pulmonic. So I'm going to listen with both the diaphragm and the bell.
Why?
Because I'm listening for murmurs. And a lot of times you can hear them better if they're high pitched if you have the bell as opposed to the diaphragm. So we're going to listen with both so you can detect it. Now if you have, I have a master cardiology stethoscope that I use at work. So mine doesn't have a bell and a diaphragm, but mine's based on the amount of pressure I place on the chest. But you guys have these kinds, so you'll flip yours. Okay. So aortic. Right sternal, second intercostal space. Pulmonic, left sternal, second intercostal space. Next is going to be what? Anybody? Tricuspid. Left sternal, fifth intercostal space. Then next is going to be mitral. Anybody? Fifth intercostal space. Midclavicular. Right here. Sound familiar to you guys? We're going to listen down here. What else is that known as? Yes, but what is that called? PMI. So this is going to be our PMI. We're going to listen there. Okay? So those are your spots. Aortic, pulmonic, tricuspid, and your mitral or your PMI. So if I ask you landmarks, how did you find that? Where is it at? You're going to have to tell me. Second intercostal space, right sternal border. Left sternal border, second intercostal space. I expect for you to know those because how else are you going to find them? Right? All right. So when we're listening for PMI, mitral, fifth intercostal space, midclavicular, and the heart's on the left side, so that pretty much should, you know. All right. If you have any murmurs, you need to make sure you document your murmurs or what you're hearing, if it's a systolic murmur or where you were at when you actually heard that. Is an S3 audible normal on a adult patient? You guys know you hear S1 and S2, your lub dubs, yes? S3 is not normal usually for adult patients or a patient over 30 years of age. So that would be something we'd want to listen to, maybe have someone else listen and then maybe notify the clinician. All right, so next we're going to, and make sure you're familiar with heart sounds, S1, S2, S3, S4. And when I say S1, S2, S3, S4, what's normal, what do you expect, and what is not abnormal, or what's not normal and that is abnormal. So you need to be familiar with those. Murmurs and rubs, S1, S2, S3, S4, so you're going to need to read up. You're going to test your skin for skin turgor, and you have a couple of options. You can check right here on the wrist, on the radial, and that's where we kind of pinch the skin up. We're assessing for hydration. So if we pulled it up like this and pulled it into, pinched up, and it stayed kind of in a tent shape, and it took it a little while for it to kind of go back down, what would that be indicative of? Dehydration. And if we pulled it up and it just went right back, then we're good, yes? Mm-hmm. So this is a spot you can use. A lot of people like to use right up here by the clavicle, and that's fine. You can pinch up there. Either place is sufficient to check for hydration. All right, so inspect and assess sensation, movement, strength of the arms, hands, and fingers. It's important to know that your patients can move all of their extremities, and we need to see that. So a couple of things you can do is just watching them. Are they moving their arms? If not, you can have them put their arms out in front or put them above their head just to move them down to make sure they have range of motion. Then I typically have my patient close their eyes, and say, I'm going to touch you on one of your hands. Tell me which one, and I'll just come over and tap their fingers, and they'll say my left hand or my right hand to tell me that. When we assess strength on the patient, so we have range of motion and we have sensation already. When we assess strength, it's important that you do it together, because it's hard to have them squeeze this hand and then go here and you're like, well, I don't know which one. So I just have them to assess the strength. I'll just have them put 2 of my fingers right here in their hands and say squeeze with both hands at the same time as hard as you can. And just have them squeeze. Then I can assess their strength. Do they have equal strength, bilaterally equal, or is the left side a little bit weaker than the right side? So that would be important to document as well. Capillary refill. We're going to want to check your capillary refill. What is normal capillary refill? Less than 3 seconds. So we're going to assess capillary refill. And it's best if you do it on both hands. Some people will just do it on one hand and say, oh, capillary refill's good. Well, what about this arm over here? So it's check it on both sides. Should be less than 3 seconds. Okay, everybody knows how to check capillary refill. You take their hand like this and you're going to pinch down. And it's going to turn white, and then when you let off, you're going to look for basically reperfusion to see how quickly it goes back. Okay. All right. Any questions so far?
I just have one. Are you documenting as you go? I mean, do you have something here and you?
Well, this assessment takes me probably about 5 minutes to do, but since I'm showing you guys how to do it, I keep all of it in my head. The only thing that I write down as I'm going, if I need to, is anything that's abnormal.
Okay.
Because if you're writing down all the normal, it's going to take you a long time. So you should already know in your head everything that's normal. The only thing you should have to write down immediately is abnormal stuff. Then when I complete the whole assessment, I'll make just a quick note to myself, blah, 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 whatever, and put any abnormalities on there, and then I go do my next assessment. Because I don't sit down to chart till I'm done with everybody. So I just have a brain paper that has all my stuff. For each patient, I document that. So next, we're going to assess pulses. So make sure you guys know where all your pulses are, because you'll be tested on that on assessment. So that means carotid, brachial, radial, femoral, popliteal, posterior tibial, and your pedal pulses. So you'll need to identify all those pulses, so you need to be familiar with them. So radial pulses, I'm going to assess up here. Pulses are the same thing as strength. You need to assess the pulses together because you're looking for equality. So if I check this pulse and then I go over here, am I going to really know if their pulses are equal? Probably not. So I always assess the pulses together. So I'll assess both the radial pulses at the same time to make sure that they're equal pulses. And then I'll document, are they normal? Are they +2? Are they above normal +3? Are they bounding +4? Are they weak? Or are they absent? Okay, so there's +1, +2, +3, and +4. Be familiar with those. So if you say, or if I say, okay, your patient had a +3, had +3 pulses, what does that mean? And you'll tell me, oh, that, well, +3 means it's stronger than normal, or whatever it is. And that, so you need to be familiar, because if you're going to document it, you need to know what you're documenting. So you're going to chart your pulses. Next thing is going to be IV site. If your patient has any IV sites anywhere, you need to document IV sites. Most likely ours won't, because we don't put IVs in these guys, but sometimes we'll tape them on there. So say this guy has an IV right here. What is something we would document about it? First, we would document the location, right? So we would say right antecubital area. I would look at the size of the catheter that's inserted. Is it a 20, 22, 18? That would be documented. And then I would also document the date that it was inserted. Because usually most policy is 48 to 72 hours. Some go to 96, but that has to be changed. I'm also going to document the appearance. Any redness noted, any swelling noted. If not, then I would put no redness or swelling noted. I'm also at some point going to want to flush this IV if there's not fluids hanging with it, and make sure that it's patent. If it's just a saline lock, I'm going to make sure it's patent. So that means it's functional. If there are fluids hanging to it, then I need to document the type of fluids that are hanging. Normal saline at 100 cc's per hour. Does that make sense? So if there's fluids that need to be documented, the site needs to be documented. And when we say site, what does the site look like? What size of catheter do you have? When's it due to change? And is it patent or not? Okay. If there's swelling and redness, then we could have an infiltration, or we can have infection, or we can have both. So site, describing the actual site, what it looks like, is very important. All right, so GU system, and I added this on because on the last thing there was no GU system. Okay, it wasn't on there for checkoffs before. The GU system is important because number one, we need to know that your patient can actually urinate. That's kind of important, yes? How much should your patient be urinating at minimum per hour? 30 cc's per hour, minimum. If they're not, then we
You will
have
see
problems.
that question on a test.
Yeah.
Whether it's Miss Perkins' test or not, you will see that question.
So 30 mils per minute or per hour, if they're below 30 mils per hour, we have problems. So when I'm looking at my patient as far as GUIs, I need to know, is the patient voiding in a bedpan? Is the patient getting up to the bedside commode? Is the patient walking to the bathroom on their own, or do they have a Foley catheter in? So depending upon what's going on, I need to assess the urine or know about the urine, correct? So I'm going to look to see how much urine they've put out in the last 24-hour shift. I'm going to ask the patient, if your patient's alert and urinary times 3, you can ask him, if they're using the toilet, what is your urine, when's the last time you urinated, and how much was it or what it looked like, because we usually put the hats in there and they'll tell you it was yellow or it was concentrated or it smelled bad or whatever. If they have a Foley, we're going to check the bag, we're going to look at the urine, the amount of the urine, and we're going to look at the insertion site here to make sure that it's clean and that the drainage system is set up appropriately. So Foley catheter bags don't go under the legs. Sometimes you come in and there's nothing in the bag and you're wondering why. You look, it's because something's been sitting on it all day, which is not good for the patient. So you need to make sure your system's set up correctly if they have a Foley catheter when you're assessing that. So if he had a Foley catheter, I would actually come down here, look down in here, check the site to make sure that it looks okay and that it's set up correctly. I would follow it all the way from the site insertion all the way down to the bag to make sure that nothing is messing with my system. Okay, it's draining fine, it looks good, and then I would cover it up. Okay, so make sure you assess about urination. That is important. And plus, when your patient needs to go, if they don't have a Foley, you need to know how you're going to get them there or how they're going to get there. Abdomen, we're going to inspect the abdomen. I always ask every single one of my patients every day, when's the last time you had a bowel movement? And sometimes they'll tell you first thing when you come in the room. You don't even have to ask. But I always ask, when's the last time you had a bowel movement? And a lot of times if they'll say, well, it was a couple days ago, I'll say, well, tell me about it. If it seems like it was traumatic, tell me about it. And they'll say, well, it was a little bit hard or this or that. You can get it. But the biggest thing is to find out when's the last time that they had a bowel movement. The last thing you want to do is to get a patient that came in that hadn't had a bowel movement for 7 days. Because then you're going to end there doing all kinds of laxatives and probably having to disimpact somebody, which is not a good time. So, abdomen assessment, and this is important, so we're going to look at his abdomen. And this guy actually has some little stomas here, but we'll pretend they're not there. So first thing you're going to do is inspect. So we're going to look at the abdomen, look for any types of rashes, breakdown, incisions, whatever. Next, I'm going to auscultate. So I'm going to take my thing here and I'm going to listen to all 4 quadrants. For how long? How long?
5 minutes each quadrant.
5 minutes each quadrant.
Let's say that sounds.
I'm going to listen for bowel sounds. So it's important that you know what hypo, normal, and hyperactive bowel sounds sound like. Make sure you read in your book and it'll tell you how many gurgles you should hear. So when I'm listening, I'm going to listen, and if I hear normal active or hyperactive, I'm going to move on to the next. Once I've heard at least, normal active, if they're hypoactive, I'll listen a little bit longer, but you can move on. Now, if I listen to a quad over here and I don't hear any bowel sounds, I'm going to listen for a full 5 minutes, and if I don't hear anything, I'm going to go get another nurse, and I'm going to have her listen to that for a full 5 minutes. And then if she doesn't hear anything, then I'm going to call the doctor. But always get 2 sets of ears, because sometimes you might just have your ears might be off. So I always, if I don't hear it, I get one other person to check before I call the doctor. Okay? So if you did not hear bowel sounds, that's when you would listen for a full 5 minutes in that quadrant. So I'm going to listen to all 4 quadrants here. Okay? Next thing I'm going to do is I just palpate. And the reason I palpate, obviously, I'm going to be palpating over here to see if I can feel their spleen. Should you be able to feel someone's spleen? Spleen's on the left over here. If you can get up there and you feel somebody's spleen, we have problems. I palpate over here. I'm going to be feeling if there's any type of liver, anything like that. You should not be able to really palpate somebody's liver or anything either. You can feel it, but it should not be enlarged coming way out here where you can just, feel on it. Any type of pain obviously is an issue, right? No one should have abdominal pain. If they do, we need to document it. You need to document what type of pain, where they have it, and so forth. Next thing, you're going to percuss, and it should show you, and you guys don't have to do the percussion and stuff. I would recommend you doing the auscultation and the palpation, because you're going to auscultate for bowel sounds and palpate for pain. Percussion is a bit advanced, and you guys can just look over the percussion. I'm not even going to show you that. Just look over it, okay? So that's going to be it for abdomen. Any questions?
So how long in general are you saying to listen to the 4 quadrant?
I usually listen to each one for about 20 to 30 seconds, and I usually have the information I need by then, because they're either going to be really hypoactive. If they're hyperactive, you're going to hear it, and if they're normal active, you're going to hear it within 20 to 30 seconds. If you don't hear anything, I usually listen a little bit longer, and if I still don't, then I'll just go ahead and set my clock and listen for the full 5 to see if I hear anything. If I don't, I go get someone else.
And
All
make
right.
sure you have the order of that down, when you do what you do first, what you do
You
second,
inspect
what you do
first.
third.
You need to make sure you inspect first, because anytime you touch the abdomen, you can increase bowel sounds. So you inspect first, auscultate second, and then you can palpate and percuss.
Make sure you know that.
Yeah, because that'd be important. Perineal area, I've inspected that when I looked at the Foley. So you're going to want to look down here for any type of rashes or breakdown, especially with your incontinent patients, or yeast or anything like that. Next, we're going to look at the legs, and what I usually do is I just come down this way and I pull these up like this for them. So that way it kind of provides a little bit more privacy for them. And now I'm seeing this half of the body, so I'm going to look at the legs. I'm going to do the same thing with the legs. I'm going to have them stretch their legs out, move their legs to make sure that everything's moving appropriately. And then when I assess for strength, I'm going to have them push down, which is called what? Plantar flexion. And then I'm going to have them pull back against me. So I'm going to have them do that, and I'm going to check both ways like that. Same thing with sensation. I have them close their eyes and say, I'm going to touch one of your feet. Just tell me which one, and I'm going to tap their foot. They'll tell you. I'm going to check capillary refill while I'm down here, because I want to make sure, and I'm going to check it on both sides. Yes. And then I'm going to go ahead and check pulses. I'm going to check his pedal pulses. I'm going to check his posterior tibial pulses here, so you need to know where those are going to be located. Okay? Popliteals are right here, and you guys know the femorals are up in here. So you want to check pulses too. And then again, make sure that you understand how to document those pulses. +2, +3. If you have a patient who has an absent pulse, what are you going to do? They don't have a pulse. So I check his foot right here. It has no pulse. I can't find a pulse anywhere. What do?
Get a Doppler.
I'm going to get a Doppler, see if I can find it with the Doppler. So I find it with the Doppler, so what am I going to do now? I'm going to mark it with a Sharpie so that the next person does it. And then I'm going to go ahead and notify the physician and let him know that I had to get this by Doppler and what I found, just to let them know, and then I'm going to document that. Okay? So again, +4 is bounding, 3 is stronger than normal, 2 is normal, and 1 is weak and thready. May need a Doppler, and 0 is absent. So if you mark 0 for absent, you better have an intervention, because if we leave somebody here with no pulse, this leg's not going to last very long. He'll be going down to the OR to have an amputation. So make sure you document. And then while we're down here, you guys are also going to be looking, especially primarily in the lower extremities, for any type of edema. So pitted edema, non-pitted edema, make sure you read in your book the difference in the two. Some people just have generalized edema or anasarca, where they're just puffed up like a toad. But when you push down, it's not pitted. Okay, so sometimes it's just not pitted edema. Sometimes it is pitted. So know the difference in the two. If I push down on his ankle, and if any of you have been pregnant, you probably had pitted edema on your ankles. So you push down on here and it leaves my fingerprint in there. What would that be indicative of? Pitted. And then I'm going to look to see if it's, 2 millimeters or 4 millimeters or whatever. So +1, +2, +3, +4, and you need to know the amount of millimeters of depth that each one consists of. Okay, so make sure you read over that in your skills book. Then you would document that. If I had a patient that had edema, what intervention would I want to do? I'm going to elevate their extremities. So that is something you'd also want to put. Noted +2 bilateral edema, bilateral lower extremities, elevated to help prevent. So that's all stuff you're going to document, because that's showing that you found something abnormal and you did an intervention to save your patient. And that's what the board's looking at, because they're wanting to incorporate into the boards now hands-on type stuff that you'll have to do to take your boards to pass your exams. So elevate the feet. Okay. So I finish all this up. Next thing I'm going to do is, am I going to leave my patient like this? No. So I'm going to straighten my patient back up. Straighten his bed up. He's heavy. Do that. Cover him back up. Biggest thing is, now that I'm done, my side rails are up ×2, which is the minimum. his call bell's in reach right here, and the patient's comfortable, and then I can go wash my hands, leave the room, and document. That's it. What do I what?
To look.
To look, if I would look at his butt, I would roll him over, but he's set up, I could see the bottom of his butt, and I assessed his peri area right here, so I pretty much saw it. Now, if it's one of those little tiny patients and they can't sit up this well and do that stuff, they would need to be turned completely side to side. But I've pretty much seen all his back, all this, I've seen his arms, his legs, his peri area, and I could see all the way down his crack on the back there to make sure there was no breakdown. And you guys will actually be doing assessments on each other, so you'll be able to help sit yourself up and do all that, so we won't have to mess with this, because this is a pain when we have to pull the dummies around. So it'd be a little bit easy for y'all. I guess I should have had one of y'all come do this for me instead of a dummy, now that I think about it. Anyway, hindsight. So that is assessment. And it's just basically, I can come in and just start from here to there and just go through it, but I've been doing it for a few years. So as you get used to it, you just come through and you just remember to check everything and go down. Once you get this, you got it.
And I really think it's important to practice on living people
Yes.
as opposed to just the dummies, so that when you do the cardiac sounds, you hear it.
Mhm.
Do it on somebody at home. Do it on each other. You're gonna have lots of time to practice.
You don't have to see every inch of each other's skin, just let's throw that out there. You can just pretend that you did, but as far as listening to heart sounds and breath sounds, you can do that over someone's shirt or just right there so you guys can practice on each other.
Definitely get your pattern down for
Yeah.
listening to lung sounds.
Because I've seen people come and they'll listen the whole right side and they'll come listen. How are you comparing those sounds? Everything is a comparison. Everything is supposed to be normal, so we need to know what normal is so that we can identify the abnormal, but everything has to be in comparison. Pulses, strengths, everything. So think about it that way. Everything is a comparison within the body. When you have two, it's all comparison. Any questions?
Oh, I'm sorry. I thought when I read it there was height and weight on there. Do we not need to do that?
That's at the front, and that's going to be on your chart.
Okay.
That height and weight and vital signs, that's all stuff that is going to be on your chart already. If it's not, then you would want to get it, but that's more like of an admission thing, because most of our drugs are weight-based, so we always want to know height and weight. But if you don't tell me height and weight, I'm not going to fail you. Okay? Just know that you want to make sure the weight's on there, so if they did have to go down to the OR or anything, that's what they're going to base it on. But on admission, everybody gets in there and they get weighed either before they get in the bed or weighed on the bed scale when they get into bed. Okay? Any questions?
The soles of the feet, any special considerations for that?
You'll look at the soles of the feet when I'm down here looking at their feet and assessing their pulses and looking for edema. You'll look because, especially the heels, because there can be breakdown. Like this guy, for example, he has a lot of breakdown and he has actually V-cubes on his. So when you're looking at the feet, the soles are very important to look at as well as the heels to make sure there's no breakdown.
Just made me think of some
Yeah.
diabetic patients.
Yeah, you get diabetic patients, you get patients that are bedbound, a lot of
They
them
would
have
have a nail
breakdown.
there and not even know it or something like that.
Yeah, they can have all kinds of stuff there, tacks stuck in their foot and all kinds of stuff. So yeah, I always usually just take my hand and rub it across the bottom of the foot and make sure, and if they have any pain, or a lot of times they'll tell you, I have an ulcer down there that they've been working on, or a wound or whatever. Some of them ask you to clip their toenails. We don't clip anybody's toenails, period, and especially not diabetics. Because if you go in and clip a diabetic's toenails and it gets infected, and we have issues and they end up losing that foot, they're going to be coming for you. So if you were to see an ingrown toenail or anything with a diabetic patient, that is something you would want to notify your charge nurse and physician about, so they can consult a podiatrist to come up and take care of that. But we don't do that. I've had people say, can you cut my nail? Sorry, I'm not a beautician. I cannot do that. And I usually tell them that if they're diabetics, they already know. They should not be asking anybody and not doing it themselves. But if they're regular people, I'll just say, you can have your family bring a file or clippers and you can do it, but as policy, we're not allowed to do that. It's just a risk you take doing that. Even if they look like one of the Bearstein bears, you're not really supposed to touch their feet or their hands. I know sometimes feet are a big thing with me. You pull it up and you're like, whoa. They have like toenails this long and they're curled up and you just want to put the sheets back down, but we can't touch them. So it's something you can talk about with the doctor, see if he wants to do a consult with a podiatrist or something like that, but we don't do all that stuff. But yeah, feet are important. The coccyx important, scapulas are important, the whole back, even the back of the head. And another place that a lot of people don't look that's really important to look is over the top of people's ears for those who are wearing oxygen for extended periods of time. Because those little tiny people, your COPDers, are on steroids for long periods of time. They have that paper skin, and they put those plastic things over their ears. Their little ears get rubbed raw on the top. So I always check there, and a lot of times I'll wrap foam tape around the oxygen tubing so it's kind of cushiony there and not just digging into them. If they're on oxygen, that's another good reason you want to look in their nose, because oxygen dries people out. So a lot of times we'll put a humidifier on there and make sure we're not cracking their nose and bleeding, because then they get a bunch of issues in there. So a lot of information, but you're getting the basics now. You'll pick a whole lot up once you finish school. Experience gives you a lot of stuff once you get out of here. So don't feel overwhelmed, just get it down and get comfortable with it. Know the normals. That's the most important for you right now, is to know the normals. Because if you know the normals, how can you not know what's abnormal? So knowing the normals. Make sure you know your vital sign parameters, because you'll be asked that when we say your patient has vital signs of this or those with the normal parameters. And that can get you failed big time, because you've already checked off on it, so you should already know what the normal parameters are. So if you check off with me, I'll tell you you're going to get asked the vital signs. All right? So y'all can go practice.